Good day, class. Today our lesson is both exciting and scary. Today we will learn how to prevent postpartum hemorrhage. We will look at the definition, predisposing factors, causes, and then we will look at how to specifically manage the third stage of labor to prevent postpartum hemorrhage. The acquisition of this knowledge is vital since postpartum hemorrhage is the leading cause of maternal mortality and our goal is to decrease this occurrence. What is PPH? The American College of Obstetricians and Gynecologists, ACOG 2017, defines PPH for both vaginal and C-section delivery as blood loss equal to or greater than 1,000 mils, with signs and symptoms of hypovolemia. What are the signs of hypovolemia? Signs of hypovolemia includes tachycardia, hypotension, vaginal bleeding, cold, clammy skin, excessive sweating, shallow and rapid breathing, drowsiness, fainting, and cyanosis. ACOG reports that PPH occurs in every 1 to 5 delivery, with an increased prevalence rate of 26% between 1994 and 2006. As skilled nurses, we can lessen the occurrence of PPH and save lives. All pregnant women are at risk of having PPH. However, there are some predisposing factors that places them at greater risk. Multiple gestation, large baby, and increased parity overdistends the uterus and places them at risk for uterine atony. Augmented labor, prolonged labor, chorioamnionitis, maternal anemia, maternal obesity, and preeclampsia are other factors that predispose women to postpartum hemorrhage. Healthcare workers should strive to identify these risk factors and actively manage these patients to minimize the occurrence of PPH. There are 4 major causes of PPH, and we use the 4 T's to remember them: tone, trauma, tissue, thrombin. Let's look at tone. 80% of postpartum hemorrhage occur because of uterine atony. Uterine atony is the failure of the uterine muscles to contract adequately. So what can we do to alleviate this atony? We can look at the predisposing factors and try to eliminate them, and we can use active management of the third stage of labor to prevent and manage uterine atony. Trauma. When we speak about trauma, we're speaking about cervical, perineal, or labial laceration. These lacerations result in significant blood loss, but they can be managed. And how they are managed is by timely hemostasis and quick repair. Tissue. We're speaking of retained placenta and or its membranes. Retained placenta prevents uterine contraction, leading to uterine atony. Manual removal may be necessary if the placenta is retained more than 30 minutes after delivery. Invasive placenta cannot be removed manually, and so placenta accreta, placenta increta, or placenta precreta may require a hysterectomy. Last but not least is thrombin. Coagulation defects such as hemophilia and disseminated intravascular coagulation are the least common causes of PPH, but they can be fatal. Treatment include maintaining intravascular volume, identifying and treating the cause of these defects. Repetition reinforces learning. So again, to reduce the incidence of PPH, we must identify and manage both the risk factors and the associated cause. And next, we will learn about the active management of the third stage of labor. Active management of the third stage of labor involves the use of uterotonics, controlled contraction, and fundal massage instead of the traditional expectant approach that allowed spontaneous placental separation, natural hemostasis, and late cord clamping. The efficacy of this form of management has been recognized and recommended by ACOG in 2017 and the World Health Organization in 2018 for all expectant mothers. Begley et al. In 2019 reviewed Cochrane analysis and provides evidence that the active management of third stage of labor decreases postpartum hemorrhage incidence and minimizes blood loss to less than 1,000 mils. Let's take a look at each component. Uterotonics are drugs that increase uterine contractions and improve uterine tone. Evidence indicate that a prophylactic uterotonic administered in the third stage of labor will reduce blood loss, and oxytocin is the most effective agent. ACOG 2017. Gordok et al. 2018 highlights the benefits of the uterotonic administration in increasing uterine contractions, facilitating placental delivery, and lessening blood loss. Some of the uterotonics that we currently use are oxytocin, which ACOG said was the most effective agent, ergometrin, misoprostol, hemabate, and tranexamic acid. Controlled contraction, otherwise called the Brandt-Andrews maneuver. Controlled contraction involves applying firm traction on the umbilical cord with one hand while the other hand uses suprapubic pressure to assist with placental delivery. Coolini and Williams 2016 suggested that controlled contraction lessens PPH occurrence and decreases the incidence of retained placenta. However, this procedure is sometimes avoided since it increases the risk of uterine inversion if not competently performed. Fundal massage is used to stimulate endogenous prostaglandin secretions, which promotes uterine contraction. Studies done by Aboshady et al. In 2018 prove that uterine massage reduces postpartum blood loss and recommends its practice in the prevention of postpartum hemorrhage. Learning has taken place. We now know that postpartum hemorrhage is blood loss 1,000 mils and over with signs of hypovolemia, and it is the leading cause of maternal mortality. We know that various factors cause postpartum hemorrhage, but we also know that we can decrease the incidence of postpartum hemorrhage by managing the predisposing factors and practicing active management of the third stage of labor. I know you have learned a lot, and I hope you're no longer scared, but you are intrigued to go and reduce the incidence of postpartum hemorrhage. Attached are the references I used. You may take some time and read through them to improve and increase your knowledge. I thank you.